So my name is Dan Weiss from the University of Vermont, and welcome to the session on regenerative and bionic medicine. Unfortunately, Kath Bullard, who is going to chair the session, was stuck in Washington, D.C. with the storms that hit the East Coast. So she's not going to be able to make it, and so Don Finney and I will take over and do her duties for her. We've got an exciting program this morning, and let's just jump right into it. What we're going to do is have 25-minute talks and 5-minute for Q&A between each of the two talks. So what I'd like to do is talk about cell therapeutics. And this room is set up in a funny way, so we have to walk over here to use the laser pointer. So if you're sitting over there, you might want to come over here. Anyway, and if you could turn down the lights. Great. So cell therapeutics for pulmonary diseases and critical illnesses. And why do we do this? Unfortunately, the truth is that many, if not most, lung diseases remain curable. There is no cure for emphysema, pulmonary fibrosis, cystic fibrosis, and a number of other even more rare lung diseases. And the end of the day for end-stage patients, lung transplantation is the only option, but there are difficulties with both supply of available lungs and also the sequelae. If you're lucky enough to get a lung transplant, 5-year survival remains only at approximately 50%. So we were looking for a variety of new approaches in the regenerative medicine arena. And one way to think about this is that not all pulmonary diseases, not all critical illnesses are the same, and we'll get into this a little bit more. There are acute, high-intensity, transient inflammatory states like the acute respiratory distress syndrome, sepsis, septic shock. There are chronic inflammatory diseases like cystic fibrosis or asthma, and then there are chronic destructive diseases like emphysema or idiopathic pulmonary fibrosis. And each of these will take a different cell therapeutic or regenerative medicine approach. So what's our goal? Is to take this destroyed, chewed up emphysematous lung and get it somehow back to a normal structure and importantly a normal function. And so we'll talk a little bit about the endogenous progenitor cells in the lung and the state of the field with those. We'll talk about not so much gene therapy or cell engraftment, but functional repair and immunomodulation with one particular type of cell, the mesenchymal stromal cell. And we'll also talk a bit about the science fiction of trying to grow new organs outside of the body. And during this, we'll touch on a variety of cell types, including embryonic and induced pluripotent stem cells. So how do organs repair themselves? So every adult organ, and this is not fetal, but this is in developed individuals, have a small population of cells that have the capacity, should there be injury to the resident differentiated cells of that tissue or organ, to proliferate and differentiate to repopulate or replenish any type of injury. So they're found in every organ, and in the lung it's quite complex because there are at least 40 different cell types. If you start here from the trachea and move down the airway tree down to the alveoli, there are a variety of different types of cells. So to try and recapitulate the normal architecture, structure, and function after injury is difficult. And in the schematic here, you can see that up here in the trachea, very colorfully, there are ciliated epithelial cells shown in green, mucin-producing cells, goblet cells shown in yellow, and then underneath this differentiated pseudostratified layer, there are a small population of what are termed basal epithelial cells. And these are in the upper airway. If you move down the airway tree and go down to the alveolar regions, you can see here the broncho-alveolar duct junction. There are other populations of cells that have been described that, like the basal cells, have the capacity, should there be an injury to that particular region of the lung, to differentiate, proliferate, and re-epithelialize, if you will. Now, there's only a limited capacity to do so, and one of the evolving theories over a number of years in the pathogenesis of a disease like emphysema is that part of the problem is that the resident progenitor cells cannot do their job well enough to counteract the destructive influence of cigarette smoking and the like. And the situation is really quite complicated because there are so many different varieties of cells that have been described. And one of the problems with the field in endogenous progenitors in the lung is that a lot of the phenotyping has been traditionally done by cell surface markers and by things like flow cytometry. the world is changing because RNA-seq and other techniques are better able to identify these cells, but a lot of the difference between different labs reflects difference in windows on flow cytometers, and it's not uncommon that multiple labs are working on the same progenitor cell but don't fully appreciate it. So, complex, evolving definitions. Most of the data on progenitor cells still is in mice. We still have less robust understanding in humans. Homeostasis is not well understood, and they're a number of years from clinical application. But what's really interesting is that there's a potential role of the basal epithelial progenitor cell as a lung cancer stem cell or a tumor-initiating cell. And in this schematic from Rinat Shakiev at Cornell shows the influence of cigarette smoking on these, in this particular case, grayish cells that under the various toxins, they will begin to form metaplastic undergo metaplastic transformations, and then eventually frank carcinogenic transformations. So this is a really potentially important field, particularly in terms of targeting new therapeutics, hopefully right at the basal cell themselves. All right, what about embryonic stem cells or induced pluripotent stem cells? So there's been a huge growth over the past 2 to 3, 4 years in terms of the ability to take either an embryonic stem cell or an induced pluripotent stem cell and induce them in vitro through sequential addition and subtraction of different growth factors and transcription factors to actually develop phenotypes of both airway and alveolar cells or epithelial cells. And this is a very exciting field, and this would be worth a 10-hour talk all by itself. But just to give you a sense that with various types of immunophenotyping and now more and more functional phenotyping, that you really can recapitulate embryonic lung development in a petri dish with either types of these cells, and it's moving pretty rapidly towards better path towards potential clinical implementation. It's not there yet, and no one has yet grown functional lung tissue from either embryonic or induced pluripotent stem cells, but they've turned into valuable tools because you can certainly get cells from patients with genetic lung diseases like cystic fibrosis or scleroderma or alpha-1 antitrypsin deficiency, and you can induce de-differentiate them into iPS cells and then differentiate them into various lung cells and use those to understand the cellular and molecular pathophysiology a little bit better of those particular diseases. All right, what about adult stem cells? So the bone marrow, as you all know, is a storehouse for a variety of cells, including the hematopoietic stem cell, endothelial progenitor cells, and also a population of cells that have been undergone a variety of different nomenclatures over the years, but one current nomenclature is mesenchymal-derived stromal cells. And these are cells that were originally discovered and felt to be fibroblastic-like colony-forming units that provided, in part, a stroma within which the hematopoietic stem cells could develop and differentiate. But it is turned out that these cells themselves, these MSCs, can have differentiation capacity into mesodermal origin cells like bone, fat, and cartilage. One can induce the MSCs in vitro. You can do anything to a cell in vitro to develop into cells that have phenotypic attributes of epithelial cells or endodermal origin cells, if you will. But their major function seems not to be the ability to differentiate, but rather to act as immunomodulatory cells. So one current understanding of at least some of the populations of MSCs is that they can exist as pericytes lining blood vessels, and they express damage-associated and pathogen-associated molecular pathogen receptors like toll-like receptors and what have you. And a teleological sense is that these cells are acting to survey the ambient inflammatory environment. And you can imagine in the bone marrow that what the goal is to keep a non-inflamed bone marrow niche within which the hematopoietic stem cells can develop normally. And so the cells will sense inflammatory environments, and they'll react by kicking out a wide variety of anti-inflammatory mediators. So anti-inflammatory cytokines, angiogenic factors, antibacterial peptides, and more increasingly appreciated the ability to secrete a variety of microvesicle particles, extracellular vesicles, microsomes, et cetera. And what has developed is a large literature that one can take these MSCs, extract them out of bone marrow. It turns out that they also are robustly found in adipose tissue, placenta, cord blood, and actually almost every organ that you can study will have a population of pericytes. But it's not uncommon to take these out of bone marrow, adipose, and placenta. And if one does in vitro assays, so let's say mixed lymphocyte reactions with a variety of immune and inflammatory cells, then the exposure to the MSC or their conditioned media, or increasingly appreciated the extracellular vesicle particles released by the cells, will inhibit the proliferation and infectory functions of the immune cells in vitro. And excuse me, the cells also have attributes of relatively low initial immunogenicity. They do not express particularly high levels of MHC1 or HLA-ABC. They don't really express at all MHC2 or HLA-DR, and they don't express any co-stimulatory molecules. And what that has allowed is a field of study where allogeneic transplant or transfer of these MSCs can work and provide a variety of ameliorating effects. And one also has found that the MSCs, when administered systemically, so injected into the bloodstream, for example, intravenously, will lodge in that first capillary bed they encounter, the lungs, and they will sit there for a few days. And the key point is that they don't engraft. They don't stick around. They don't turn into lung cells. But while in the lung, some of them will escape and go to other organs, but the majority will sit in the lung and release, depending on the inflammatory environment, again, that range of anti-inflammatory effector molecules, if you will. And then they're cleared. And so what this has led to is ever-expanding panoply of clinical investigations in a wide range of autoimmune and inflammatory diseases. And some examples here: one of the initial targets was graft-versus-host disease, disease following generally allogeneic bone marrow transplant, Crohn's disease, multiple sclerosis, type 1 autoimmune diabetes, what have you. And these therapeutic approaches using MSCs, allogeneic MSCs, have advanced to where they are approved in Canada and New Zealand for refractory pediatric graft-versus-host disease. What about the world of lung disease? So there are now probably over 200 publications at least showing that one can take mouse models or large animal models such as sheep, or even explanted human lungs that don't get used for transplantation, and induce a range of different lung injuries. So anywhere from acute bacterial infection to emphysema to, in the pediatric world, bronchopulmonary dysplasia, asthma around the horn. And in virtually every case, one can take those animals or those lungs, instill the MSCs or now their conditioned media or their extracellular vesicle particles either down the trachea to have direct access to the lung, comparable, of course, to recombinant viral or liposome-mediated gene therapy approaches, or inject the cells, vesicles, or conditioned media systemically, and you can ameliorate your particular induced lung injury, right? And the mechanisms, again, involve anti-inflammatory cytokines, peptides, what have you. There is some growing evidence that there may be some role of cell-to-cell contact and connexin 43 mediated intracellular cytoplasmic bridges that can work, for example, to transfer mitochondria from the MSC to a cell. And there is some evidence too that the effect on lung is indirect. So for example, a disease like asthma is a T-cell mediated disease, and some of the effects of the ameliorating effects of the MSCs may reflect the fact that the cells will influence T-cell populations in draining lymph nodes or the spleen as opposed to directly acting on the lung. So this led to a trial a number of years ago, sponsored by Osiris Therapeutics, and I have nothing to disclose with Osiris, except that I was the lead investigator on this trial as an academician. And this was a company that had put its stamp on the MSc clinical therapeutics field, initially with graft-versus-host disease and moving on to cardiac diseases. And they, as a company, wanted to enter into the respiratory field. And we explained that COPD as a chronic destructive disease may not be the best disease target for a cell-based therapy, and that really, if the cells are injected, end up in the lung for a few days and then are cleared, that their best utility would be in a high-intensity inflammatory condition like acute respiratory distress syndrome or sepsis, septic shock, that COPD may not be the best target. But if you're a pharmaceutical company in the lung world, unfortunately, COPD is your best target because that's where the disease populations are. So this was done as a phase 1, phase 2 trial. The primary outcome was safety. We didn't know if there was going to be any deleterious effects in an older, sicker population with bad lung disease. But you can see the trial design here, 4 infusions, 1 a month over the course of 4 months, shown with the arrows, and then there was a 2-year follow-up period. Primary outcome safety, secondary outcome was pulmonary function test, exercise capacity, health-related quality of life questionnaires, and you can see the breakdown of the 62 patients, and all of them went through the infusions, and a good proportion made it through the 2-year follow-up. We did 10 patients at my university, and so 4 infusions each. So I sat through 40 infusions at the bedside because we just didn't know if there was going to be any acute infusional toxicity, but there were no signs or symptoms of pulmonary embolus, which was the major toxicity we were concerned about. No serious adverse events in the 2-year follow-up through a variety of endpoint assessments. The study was underpowered for efficacy, so we didn't have that eureka moment where everyone's emphysema got better. But what we were able to convince the company to do was to add, in addition to circulating toxicology with electrolytes and liver chemistries and the like, to add a panel of inflammatory and anti-inflammatory circulating cytokines. And so we found that, very surprisingly, something called C-reactive protein, which is an acute phase reactant that's often elevated systemically in the blood of patients with emphysema, actually went down significantly during the infusion period and then remained low, although losing statistical significance over the 2-year period. And so this was a novel finding and one that was opening up doors to hypothesis generation for future clinical trials. So a next step in this was a situation in Sweden in which 2 patients with ARDS were dying, and through a compassionate use of allogeneic bone marrow MSCs, one patient had H1N1 flu, the other had post-chemotherapy for AML. They had clinical improvements almost immediately after MSC infusion. Now we cannot attribute the clinical improvement to the MSC infusion because it wasn't a clinical trial, rather compassionate use. But what we're able to do, and it's a lot of data here, but what this in summary means is we were able to measure on blood and bronchoalveolar lavage fluid a variety of pro and anti-inflammatory cytokines and things like circulating stimulatory and anti-inflammatory miRNAs, and then correlate these to in vitro potency assays in terms of mixed lymphocyte reactions and the like. And the idea was to try and build up a database where we could get a better understanding of what these cells are actually doing when infused into an acute lung injury type situation. So clinical investigations of MSC-based cell therapies in lung diseases, still mostly phase 1 safety, dose escalation of very few limited phase 2 efficacy. And to explore a little bit better, we don't know, and I think the MSC field doesn't know, and we have one of the leaders here, Don Finney, who will speak a little bit later, what we're doing. So the MSCs can be isolated from a variety of different sources, and they're similar but not necessarily the same. Autologous versus allogeneic use of MSCs. Can you manipulate the cells? Can you engineer them to express anti-inflammatory or anti-tumor compounds, for example. I'm not clear about the dosing or direct systemic versus direct endobronchial and the like. And one of the things is that unfortunately has taken off in parallel with the MSc field is that of stem cell medical tourism. So there are few cell-based therapies that really are standard of care or approved by regulatory agencies, but it doesn't stop the industry out there from trying to take advantage of desperate people. So you can go to the website and type in stem cells, and you can go to the internet and type in stem cells and lung, and you'll come up with an unfortunately large and growing list of companies that offer unproven cell-based therapies for anything you want. And this is just getting worse, and fortunately the FDA under Scott Gottlieb is taking some very concrete steps to stamp this out. And just literally last week, the FDA came out with injunctions against two of the more egregious outfits out there that are providing unproven therapy, including the one that resulted in the 3 women going blind after retinal injections a couple months ago. All right, so let me just end up with regenerative medicine and bioengineering. So you've likely seen this picture of a human ear growing into a non-skid mouse. And the idea is, can you stimulate better the body's repair mechanisms to heal previously irreparable tissues or organs? Can you grow tissues and organs outside of the body? And can you develop organ-specific adjunct devices? And so it's very successful. It's relatively successful in simpler and I mean relatively tissues like skin, bone, cartilage, but when you get to lung, liver, brain, more complicated organs, it's very difficult. And particularly in lung, where the structure-function relationship is critical and your main output that you want to recapitulate is gas exchange. So how do you do this? So you can certainly use embryonic or induced pluripotent stem cells to grow small organoids. These cells will self-assemble and start talking to each other and make microscopic little gas exchange units. And this is phenomenally important for understanding, again, cell molecular biology, but no one's going to grow a clinically usable lung from an organoid. Organ-on-a-chip technology, many of you heard about. Airway cells on one side of a membrane, vascular endothelial cells on the other side of a membrane. You can use those to study various things. What about actually growing a lung outside of the body? So there are a variety of synthetic matrices that one can utilize, and this, for example, is a gel foam sponge that under the microscope looks a bit like an alveolus, and one could see these with cells, and they do quite nicely, and then implant these into mice in which you've removed one of the lungs, and into the wound cavity put an impregnated sponge, and you can get a variety of tissue that grows out of that sponge. Here's a rib and the host rib wall musculature. But how do you hook up a sponge, or how do you hook up an artificial construct with the airway and vascular system? So the best approach seems to be utilizing decellularization of the organs. And I suspect many of you have heard about decellularization, the idea being that you can treat an organ, a heart, lung, liver, what have you, with detergents, hypertonic, hypotonic solutions, what have you, remove all the resident cells and leave the underlying extracellular matrix scaffold. So this is a mouse lung that has been decellularized. Here's the heart, here's a syringe cannulating the trachea, and this, it looks like a lung and has all the microarchitecture of the lung, but it has no cells in it, and one can perfuse this lung, ventilate this lung, grow it in bioreactor chambers, and the idea being is that if you can take a lung, decellularize it, and then recellularize it with cells from someone who needs a lung transplant, this is the holy grail, then what you've done is what the science fiction authors did 100 years ago, and you can grow tailor-made organs for an individual outside of the body. And so this has been a very exciting whirlwind over the past 7 or 8 years, but there are a lot of challenges. Here's one example of something you can do. So this is a paper we published with Darrell Cotton at Boston University, and they've developed a mouse in which embryonic stem cell GFP expression is linked to that of something called thyroid transcription factor 1, or NKX 2.1, which is active in early lung development, thyroid development as well too. And one can push the embryonic stem cells in vitro towards endodermal lineages, and then some of them will begin to differentiate along the lung lineage pathway. We can seed these into decellularized lungs, and a high power view, you can see that these embryonic stem cells are now lining the alveoli, and they're expressing markers and have a morphologic phenotype, at least, of type 1 alveolar epithelial cells. So this gives a sense of the potential of what you can do, but the issue is that there are a lot of challenges for de- and recellularizing the lung on the way to a potential clinical implementation. So how do you best decellularize it? You need to characterize what you have. How do you repopulate that lungs? 40 different cell types, and you have to put them in the right place. You don't want airway cells in the alveoli or vice versa. And then the lung is a dynamic organ, and so particularly mechanical stretch. So how does cyclic mechanical strain and stretch affect normal lung cell development and the ability of the cell that you seeded into a decellularized construct to acquire the proper function that you'd like it to have? So the other thing about decellularized lungs is that they retain the characteristics of their pathology if you do that. Here's a normal human lung, decellularized. Here's a nasty-looking emphysematous lung from a long-term smoker, and it still looks pretty nasty after it's been decellularized. So this is a phenomenal research tool for studying cell matrix, cell matrix biology in the context of lung disease. So let me leave you with, because we're out of time, one thing, which is a lot of fun. Bird lungs. All right, so all this regenerative medicine approach, stem cells, endogenous progenitor cells, immunomodulation, engineering, to try and grow new human lungs. What the lung field, the respiratory field needs also is adjunct devices that will help lung disease patients. So in the cardiovascular world, there's something called a left ventricular assist device, an LVAD. And what this is utilized, it's a pump that's hooked up to the circulation, and you can wear it as a backpack or what have you. And ambulatory walking patients who need a bridge to transplant can be maintained on this device for a while, but there is nothing available in terms of lungs. So we have the crazy idea to use bird lungs to create an avian lung assist device. And the idea being is that birds breathe differently than mammals. And so the bird lung itself is a static wafer unit. It doesn't inflate and deflate, and it's marked physiologically by something called cross-current circulation. Air goes this way, blood goes that way. So it's essentially 100% efficient gas exchange, and the air, if you follow the yellow, goes into a series of air sacs, which then pump it through that static lung, and then into another series of air sacs that will pump it out once it's finished with gas exchange. And if you think about birds, birds fly thousands of miles, and there's something called a Himalayan snow goose that can fly over the top of Everest. So wings are only part of it. It's the respiratory system which allows them to do this. So quite simply, we can take bird lungs, chickens, emus. We can get emus in Vermont, and decellularize them. It's an emu lung, decellularize, recellularize them with human cells, and then create a device that will be hooked up with pumps and oxygen supply and use this as a bridging device towards transplant. So let me finish here. Lung tracheal bioengineering. There are lots of new technologies that are going to, I think, revolutionize the field, but there's remain multiple challenges. And lung regenerative medicine as a whole, rapid advances in progenitor cell biology, no clear role as yet for embryonic or induced pluripotent stem cells in terms of therapeutics. Cell-based therapies is where most of the current clinically applicable action is occurring, but there's still a number of issues to consider. And with that, a plug, we have a conference every 2 years that some people have been to here in the University of Vermont, and this is a leading conference for the lung world in terms of stem cell therapies and bioengineering, and welcome people to attend to that. Thank lots and lots of people in my lab, lots of very wonderful collaborations. We've been fortunate with funding. And with that, let me stop and happy to answer questions. Thank you. All right. Questions, thoughts? Yes.
Nice presentation. Question on the decellularized approach. Does it make sense to allow the recellularization in vivo?
It's a great question. And so it does make some sense, but part of the difficulty with that is the vascular endothelial system. So if the vasculature is not fully re-endothelialized, so again, you've taken an organ, stripped away all the cells, including the endothelial lining of the arteries, capillaries, veins, what have you. If those are not intact when you put that organ in, the exposed extracellular matrix is a nidus for clot formation, and you'll rapidly, essentially, clot off your organ. So it's a great idea. It's just not practical at this point, unless you can do that. Yes?
I would think that airway epithelial cells and diseases like ciliary dyskinesia sort of be ideal targets for aerosolized AAV-based gene vectors. What's the experience with that?
AAV approaches for gene therapy have been around for 20 years at this point. Right? And one of the major targets, and you have some leading CF investigators in the room, has been cystic fibrosis. And the difficulty are in no particular order, but all equally important. Access, distribution, having enough vector and gene expression to correct your defect. Old data suggests that you need up to 5 to 10% of the airway epithelium to be gene corrected by whatever viral or non-viral mediated transfer to correct, for example, defective chloride current in cystic fibrosis. Then the problem is immunogenicity, repeat dosing, longevity of the signal. So gene therapy, AAV or not, has been around for a long time, and there have just been some hurdles that we haven't really been able to overcome. Do you guys want to speak to that a little bit?
Very good summary. The other comment I would say is for AAV specifically, the genes for DCD tend to be quite big, but that's a technological issue there.
Yeah, because you can do homologous recombination.
There's viral vectors that could easily infect pulmonary epithelial cells.
Yeah, they don't, but okay. But the biggest problem for viral gene transfer in the lung is repeat administration for lung cell types, which you are likely to come back with those.
Right.
That's my take. Sorry, Dan.
All right, well, thank you, Stephen. So this was a whirlwind tour of respiratory regenerative medicine, if you will. So any other questions? Yes?
In your opinion, what's the main difference between epithelial repair in the mouse and human? Thinking about models that people have been using in the past, looking at mouse cells, what do you think is the biggest difference that's going to misdirect people?
No, that's a great question. So the mouse lungs, like almost all other organs of the mouse, are harder to injure and better to respond and to repair themselves compared to human lungs. And that's just, how do you better describe it? That's the nature of a laboratory mouse. So we've been misled so many times about therapies that approach different pathways in the mouse that work wonderfully that just do not work well in humans at all. The other is that, of course, you have tools that you can utilize in mice, lineage tracing, et cetera, and the like, that you just really don't have the ability to do in the human. So more and more with clinical trials that go on, you have to ask biological questions. Any clinical trial, and we try and push this as hard as we can in respiratory, you collect blood, you collect lavage fluid, you get lung biopsies if you can, and then go back to the bench and try and do something. So that's kind of a superficial, generic answer, but it's the reality. Yes? In vitro. And it's a very important point. You can take a cell and in a petri dish, you can make it do lots of different things that it's not normally going to do. So people have tried very hard in mouse models, actually, us included, to instill or administer MSCs and convince them to turn into lung epithelial cells, and they simply don't. right? There's a controversial literature on this, but they don't. Yes?
All the stem cells use naive stem cell. If you use the gene transfer stem cell, such as for some cerebrity, non-reporting, such as you want bone formation, cartilage formation, enhanced osteogenesis or chondrogenesis, if you done any gene transfer from what type of stem cell?
So there is we have not directly done that. I'm so sorry, I take that back. We have utilized MSCs transduced to express something called TNF-alpha receptor apoptosis inducing ligand, or TRAIL. And we've used this in mouse models of lung cancer in collaboration with Sam Janes at University College of London, and in mouse models of mesothelioma. And the idea being is that the MSCs by themselves may have some anti-tumor effect, but expressing or overexpressing a compound of interest like an anti-tumor agent is a very important way to go. And so there's been a variety of approaches to do that in other lung diseases, if you will. All right, why don't we move on to, thank you, and let's move to the next speaker, Dr. Ling. All right, so unfortunately, our second speaker, Dr. Ling, may not have been able to make it, weather or what have you as well too. So we can continue for a few more questions, or why don't we move to our next speaker, and we can have more of a roundtable at the end. So.